Good morning, everyone. My name is Marc Kowalsky. I'm one of the shoulder and elbow surgeons at ONS. And this morning I'm going to be talking about the safety and effectiveness of outpatient shoulder replacement surgery. Historically, the experience of a patient undergoing shoulder replacement looked a lot different than it does today. Most people would stay in the hospital for an average of about 2 days. They may have an indwelling drain that would help to evacuate fluid and blood from the surgical site for a day or two after surgery. Patients would get blood draws every morning in order to monitor laboratory data, including blood count and electrolytes. They would have a short-acting regional nerve block to help with pain relief for about 12 to 18 hours, and then they might require intravenous or oral opioid medication for breakthrough pain. There are other reasons to stay in the hospital, perhaps, for certain surgical procedures. Obviously, it allows nurses and medical staff to continuously monitor certain data, including vital signs. If a patient did experience significant blood loss, remaining in the hospital would allow for the administration of a blood transfusion if necessary. It would allow the medical team, including the nurses and physicians, to identify complications in a timely manner and treat them appropriately. With nurses' aides, patients can get assistance with activities of daily living while in the hospital if necessary, including bathing and toileting, for example. There's also a notion on behalf of patients that a shoulder replacement is a major procedure that therefore should require a certain inpatient stay for a period of time. And of course, there's the power of the status quo, the fact that a shoulder replacement has been an inpatient procedure for quite some time, and therefore perhaps should remain an inpatient surgery. But there are many examples in orthopedics of procedures that used to be an inpatient procedure and have transitioned safely to an outpatient procedure presently. Among these examples include carpal tunnel release, believe it or not. It's almost inconceivable to imagine that a carpal tunnel release did, in fact, in the past, require an inpatient stay, and now it would almost be unheard of to perform this procedure as an inpatient unless there were mitigating circumstances or significant health reasons. ACL reconstruction is another operation that would often require inpatient hospitalization in the remote past, but it's universally an outpatient procedure in present day. There are certain spine surgeries that are also safely performed as an outpatient presently, and of course hip and knee replacements are now with increasing frequency being performed as an outpatient. So it raises the question about whether shoulder replacement can and should be done as an outpatient surgery as well. There are a couple key factors to consider when deciding whether an operation such as a shoulder replacement can be done as an outpatient. Among these include the ability to control pain and the ability to minimize blood loss. From the perspective of keeping patients in the hospital, nurses can continually monitor the patient's level of pain and then, if necessary, administer intravenous or oral pain medication. But with advances in regional nerve anesthetics and advances in what we call multimodal pain control, we are now able to send patients home the day of surgery and keep them comfortable during the days immediately after the procedure. Blood loss is also an important factor to consider. If there is blood loss anticipated during an operation, as an inpatient, patients' vital signs can be monitored continuously. If there's an indwelling drain, we can directly observe how much bleeding is taking place, and we can monitor laboratory data, including a blood count, which can be a late indicator of postoperative blood loss anemia. But there are a couple of advances that have helped us minimize blood loss after surgery. Among them is a medication called TXA. And we've also changed the way we approach patients who may or may not need a blood transfusion. The threshold for deciding who needs a transfusion has changed over time, and therefore transfusions have become exceedingly infrequent in shoulder replacement. So let's start with regional nerve anesthetics. This procedure is often done by our anesthesiologists, and before the operation, they inject a numbing medicine in and around the nerves that provides sensation to the shoulder and arm. The medication they typically use is bupivicaine, which is a relatively long-acting local anesthetic. There are ways to increase the action of the bupivicaine so that the pain relief lasts longer. One of these is the addition of additional medications like steroid or Decadron, which can make the nerve block last longer and give the patients additional pain relief after their procedure. In order to get pain relief for even longer after an operation, sometimes we used to leave indwelling catheters around the nerve next to the neck and allow this catheter to release medication slowly over time to extend the action of the nerve block. But these indwelling catheters had their own set of issues and the possibility of complications. So we now have a great alternative, and it's a slightly different kind of bupivacaine. It's called liposomal bupivicaine, or Exparel. This is a multivesicular liposomal product where the bupivacaine is actually housed within these vesicular chambers, or liposomes. When you inject the bupivacaine into the soft tissues around the nerve, these liposomes or chambers break down, which allows slow release of the medication over time. It allows delivery of a therapeutic level of bupivacaine over time, thus giving patients pain relief for sometimes days after their procedure. In fact, the pharmacokinetics of this medication have demonstrated that we can sometimes get pain relief in these patients for up to 3 days after their surgery, and excellent pain relief reliably for a couple days after their operation, which perhaps allows us to send them home and keep our patients comfortable while they're at home recovering from their operation. Liposomal bupivacaine has been examined in the context of ACL reconstruction and total knee replacement and has been shown to be safe and effective with increasing durability of action, giving patients pain relief for days after their surgery. In a recent study, the investigators looked at liposomal bupivacaine for shoulder replacement and rotator cuff repair, and in fact found reduced pain scores, increased time to the point where patients would require their first opioid medication, and decreased overall opioid consumption, which perhaps then would allow us to send our patients home safely and keep them comfortable during their recovery. Another aspect of pain control that has been exceedingly important in transitioning to outpatient shoulder replacement is what we call multimodal pain control. This refers to the simultaneous use of multiple pain medications that act at different sites within the central and peripheral nervous system in order to reduce pain, minimize opioid use, and also minimize opioid-related adverse events. And this is what our multimodal pain control looks like for a typical shoulder operation. We give patients a dose of Tylenol before their operation and every 8 hours afterwards. We give them a strong anti-inflammatory medication immediately before surgery and then for 3 days afterwards. And we give them a nerve pain medicine, gabapentin, nightly for the first 5 days. And we reserve oxycodone or opioid medication only for patients who require pain control if these other medications are not effective enough. This is a recent prospective study that looked in particular at shoulder replacement and looked at the combination of a long-acting regional nerve anesthetic combined with multimodal pain control. And what this research study found is that in fact this combination is extremely effective in managing pain after surgery. 80% of patients receiving this pain control approach use less than 15 tablets of oxycodone, and half of the patients in this cohort didn't use any oxycodone tablets at all. So in fact, opioid-free shoulder replacement surgery is in fact possible, and sending our patients home as outpatients while adequately controlling their pain is possible as well. The next sort of frontier in tackling outpatient shoulder replacement, as I've mentioned, is blood loss. There's a concern with surgeries that involve blood loss that perhaps it'd be unsafe to send patients home because they may experience postoperative blood loss anemia and may require a transfusion. In fact, blood loss after primary shoulder replacement is quite minimal. This recent study from 2021 demonstrated that average blood loss after a shoulder replacement is less than 75 milliliters, which is quite a small amount. Transfusion is also exceedingly rare after shoulder replacement. The overall transfusion rate after shoulder replacement is estimated at about 4.5%, which is quite a low number. And in fact, most of these transfusions occur when a patient comes to the operation already with preoperative anemia, or if the patient is undergoing a more complex revision or redo operation. This same research study in their cohort actually found no transfusions at all in a primary routine shoulder replacement. And an informal survey of surgeons at ONS who perform shoulder replacements routinely found no transfusions in the past 2 years for primary replacements. Well, why do we want to avoid transfusions? It's not just because we'd like to send our patients home the day of the operation, but also transfusions in and of themselves have the possibility of an adverse event or complication, including this list here, such as sepsis, surgical site infection or wound complications, or cardiac events and transfusion reactions. We can minimize the risk of transfusion by decreasing blood loss, as I've mentioned, and also by carefully examining who in fact may truly require a transfusion after an operation. Having postoperative blood loss and anemia in and of itself does not necessarily require a transfusion. Historically, if a patient dropped their hemoglobin, which is a way we monitor blood loss, below 10, that would trigger a transfusion. But we now know that we can allow our patients to experience postoperative blood loss anemia to 9 or 8, and we can avoid a transfusion while still also avoiding a cardiac event or consequence to the anemia, and their blood count will gradually increase on its own in a safe manner. So transfusions can be minimized by minimizing blood loss, number 1, and then by carefully examining who truly needs the transfusion, number 2. There's another tool we have in our tool belt to minimize blood loss when we perform shoulder replacements, and it's a medication called TXA. This medication inhibits the breakdown of fibrin clot and therefore allows patients to clot more effectively. It's been shown to decrease perioperative blood loss and therefore decrease overall transfusion rates, and it's been shown to be effective in other orthopedic procedures of the lower limb, spine, and trauma surgery. This medication has been shown to decrease total blood loss in total knee replacement by up to 48%. This medication has been researched in the setting of shoulder replacement in several papers, and the results of these investigations have shown less initial blood loss, less total blood loss over the course of a patient's recovery, and therefore decreased transfusion rates in these patients. The medication has been shown to be safe with no adverse reaction and no increase in thromboembolic events or blood clotting complications. Finally, I mentioned that in the past, we would often leave a drain in the surgical site after a shoulder replacement, which was one of the reasons we kept them in the hospital, to manage the drain. Well, drains might have some theoretical value. They allow us to directly monitor postoperative blood loss, and perhaps they would prevent hematoma formation by evacuating blood that would have gathered under the skin. But there are many reasons to avoid placement of drains. There's a theoretical risk of infection when you leave a tube that communicates from the outside world to the surgical site. Drains also might paradoxically increase blood loss because you're evacuating blood from the surgical site that would have otherwise formed clot to prevent further bleeding. And a drain requires inpatient hospitalization or skilled nursing in order to manage the drain and remove it when necessary. And finally, drains are unpleasant and painful for patients. What we found in the research is that drains in fact do not help to decrease wound complications such as hematoma formation, and as I mentioned, they do in fact increase transfusion rates by continually removing blood that would have otherwise formed helpful clot. So these investigators have concluded that the results from a large national database are sufficient to discourage the routine use of drains in patients undergoing shoulder replacement. So when we synthesize all of this information and look at the current research that has examined the safety of outpatient shoulder replacement, when you control for complicating factors such as age, other medical conditions, body mass index, and functional status, for example, outpatient shoulder replacement demonstrates no increase in 30 or 90-day readmission to the hospital, no increase in 30 or 90-day incidence of adverse events or complications, and no difference in reoperation rate whether the patient stays in the hospital or not. And this holds true for total shoulder replacement or the perhaps slightly more complicated reverse shoulder replacement. It holds true for all patients regardless of age, even those older than the age of 65. And outpatient shoulder replacement maintains an extremely high patient satisfaction rate, estimated at about 97%. This has also been demonstrated across research, not just in individual studies. In systematic reviews and meta-analyses, which are essentially a summary of the research that's been done on the topic, the safety and effectiveness of outpatient shoulder replacement has been confirmed. but it's important to choose our patients carefully. So there are some algorithms or a framework for decision making that have been offered to safely decide who can undergo outpatient shoulder replacement. And here's an example of one where we ask about age, we ask about whether there's preoperative anemia or the presence of other health complications. And if any of these things are problematic, we simply transition to an inpatient procedure. But if the patient is young with no anemia and no other health complications, they can certainly have a shoulder replacement as an outpatient. Another variation of the algorithm is the outpatient arthroplasty risk assessment. This essentially assigns points to various health conditions. You add up all the points of a specific patient, and if their OARA score is less than or equal to 110, this patient can safely have an outpatient shoulder replacement. And finally, we have to understand that the experience of the surgeon also plays a role. We've talked about patient-specific factors. Surgeon-specific factors are also important. Obviously, the ultimate goal is to minimize complications after a shoulder replacement. Well, the complication rate is already pretty low at about 3 to 9%, as opposed to 15% for hip and knee replacements. But the risk of complications and ultimate outcomes are directly related to surgeon experience. And we know that many shoulder replacements are performed by less experienced surgeons. About 75% of shoulder replacements are being done by general surgeons rather than fellowship-trained specialists. And 70% are performed by those surgeons doing less than 5 a year. So perhaps shoulder replacement as an outpatient should be reserved for those surgeons who have a certain amount of volume in order to minimize the complication rate after surgery. So in summary, this is the 5-point plan for success for outpatient shoulder replacement. Having a skilled surgeon who's beyond their learning curve, being able to safely choose the right patient for the right setting, making sure appropriate perioperative support exists, and then limiting blood loss and adequately controlling pain once the patient leaves the hospital. Thank you very much for your time.